Welcome back to Drugs and Behavior with Dr. Goodin. Next we'll be talking about Chapter 15, Drugs for Treating Schizophrenia and Mood Disorders. Drugs used in treating mental illness are often referred to as psychiatric drugs. They are generally prescribed and supervised by psychiatrists. They may also be called psychotropic medications, referring to the fact that their pharmacological effects move the patient closer to a normal state of mind. They revolutionize mental health care by easing the suffering of many individuals with schizophrenia, depression, mania, and other serious mental disorders. The biomedical model holds that abnormal thoughts and behaviors result from abnormal biochemical processes in the brain. According to this model, the effectiveness of psychiatric drugs in changing psychiatric symptoms is a function of altering these biochemical processes toward a more normal state. Drugs specifically intended to treat schizophrenia are traditionally referred to as antipsychotic drugs. Schizophrenia means split mind, referring to an individual being split away from or broken off from a firm sense of reality. They have delusions, which are beliefs not rooted in reality, that lead to feelings of persecution or paranoia. They sometimes occur in the presence of auditory hallucinations or other types of hallucinations, which are commonly in the form of voices that often torment the patient on a daily basis. There is a split between the process of thought, emotion, and action. Emotions may be dulled or absent. Verbal expressions or mannerisms may be entirely inappropriate to a given situation. They may exhibit odd postures such as catatonia. Common metals such as mercury can produce schizophrenic-like symptoms. These substances are referred to as neurotoxins. 1% of the U.S. adult population has schizophrenia. In the mid-1950s, barbiturates and neurosurgical interventions were used to treat schizophrenia, such as prefrontal lobotomies, which resulted in apathy and general loss of emotional expression. With the advent of antipsychotic medications, many schizophrenic patients were able to be treated on an outpatient basis. The number of hospital residents fell by 80% as a result of antipsychotic medications working successfully and deinstitutionalization policies. Although I don't know this research personally, the attribution of the success of antipsychotics combined with deinstitutionalization policies makes me wonder if the success rate for antipsychotics is correct, or if deinstitutionalization was just as or more responsible. Antipsychotics can be administered orally or intravenously or intramuscularly, or through injections, especially when highly agitated patients need to be subdued. Patients usually feel sedated. Agitated patients become more relaxed, while withdrawn patients become more sociable. Antipsychotic drugs have a low potential for misuse or abuse because they do not produce euphoria, tolerance, or psychological dependence. First-generation antipsychotic drugs include thorazine, Haldol, Navane, Mellaril, and Stalazine, all of which help with hallucinations and delusions, but do not help with social withdrawal, apathy, and disorientation. These side effects are typical and predictable, so much so that the drugs are referred to as typical antipsychotic drugs. Side effects may include dry mouth, blurred vision, dizziness, weight gain, oversensitive skin, movement issues, lack of spontaneity, restlessness, fixed facial expression, and loss of coordinated movement such as free swinging of the arms and walking, which are Parkinson's-like symptoms. A related side effect is tardive dyskinesia, which is a neurological syndrome that may appear after 2 or more years of continual drug treatment, consisting of jerky, tick-like movements of the lips, tongue, jawline, and face. Patients may smack their lips or flick their tongues in and out as frequently as 20 times in 30 seconds, and their walking may become progressively unsteady, or they may rock back and forth while seated. Second-generation antipsychotic drugs were able to avoid Parkinson's-like side effects and are referred to as atypical antipsychotic drugs. They do not induce undesirable movement difficulties. Risks, however, include a potentially lethal blood disease called agranulocytosis, a condition involving the loss of white blood cells and a decline in the immune system. Chlorazil-treated patients must undergo regular blood tests. Other examples include Zyprexa, risperidone, Seroquel, and Geodon. Side effects may include weight gain, risk of hyperglycemia, and the development of diabetes. They are dangerous for the elderly, doubling the risk of death due to heart-related problems and respiratory infection, such as pneumonia. With regard to third-generation antipsychotic drugs, Abilify is a prime example that has been shown to be an effective treatment for schizophrenia without the risk of Parkinson's side effects, tardive dyskinesia, agranulocytosis, weight gain, or diabetes. Advances in understanding Parkinson's disease have helped scientists also understand the effects of antipsychotic drugs. Antipsychotic drugs were thought to reduce the activity level of dopamine in the brain, implying that schizophrenia was tied to an excessively high level of dopamine activity. Understanding which dopamine receptors are targeted by a drug helps scientists understand what side effects may result. Major depression is the most common form of mood disorder at 1 in 6 American adults during some time in their life. Abraham Lincoln refused to carry his pocket knife for fear that he might hurt himself. Many depressed people turn to alcohol for relief and others turn to suicide. Only about 15% of depressed people are suicidal. When an antidepressant begins to take effect, it energizes a person slightly, enough to take action on their suicidal ideations. This is the reason that Prozac and other antidepressants have been associated with suicide. Drugs used to treat major depression are referred to as antidepressants. The first antidepressants were discovered accidentally. Early drugs were discovered to have the ability to inhibit the enzyme monoamine oxidase and were then called MAO inhibitors or monoamine oxidase inhibitors. Examples include Nardil and Parnate. MAOIs require dietary habits and restrictions on any food that contains tyramine, which must be avoided, along with other food or drink that involves fermentation or aging. MAOIs are normally used as a last resort. Another set of first-generation antidepressants involve a 3-ring portion in their molecular structure and are called tricyclic antidepressants. Examples include Elavil, Pamellar, Norepinephrine, and Tofranil. High doses of tricyclic drugs can produce an irregularly elevated heart rate and may cause danger to those with cardiovascular issues. Second-generation antidepressant drugs, selective serotonin reuptake inhibitors, or SSRIs, slow the uptake and reuptake of serotonin from its receptors at the synapse, prolonging the action of serotonin on receptors that are sensitive to it. Examples include Celexa, Lexapro, Prozac, Paxil, and Zoloft. Side effects may include agitation, sexual dysfunction, or risk of seizure. Many antidepressants have been overprescribed. There is no evidence of tolerance or physical withdrawal symptoms from Prozac or other SSRIs, but they do have a half-life. They should not be stopped abruptly, but should rather be tapered down as advised by a physician. Third-generation antidepressant drugs may be exemplified by Cymbalta, Remeron, Effexor, and Pristiq. These act on serotonin and norepinephrine and are referred to as serotonin-norepinephrine reuptake inhibitors, or SNRIs. Depression is associated with a low level of dopamine, norepinephrine, or serotonin, all of which are inhibited by MAO molecules to balance the chemical levels appropriately. When there is an imbalance, a psychotropic drug may help restore the balance by altering the faulty reuptake process and increasing or decreasing the activity of norepinephrine, serotonin, or dopamine. The choice of drug to be prescribed and used for treatment has to do with the individual and how they handle their symptoms and the specific side effects of each medicine. Different medicines work differently for different people. Antidepressants have had a 65% success rate for improvement in mood. The side effects of the medicine must be weighed against the benefits. Symptoms of mania include sleeplessness and impulsiveness. A patient and a credit card are a dangerous combination. Manic individuals may also exhibit irritability and feelings of grandeur. Others may display mood swings back and forth between depression and mania, a condition referred to as bipolar disorder. Traditionally, the primary psychiatric drug for treatment of either mania or bipolar disorder has been lithium carbonate, which is effective for 50% of patients, but requires periodic blood testing to avoid potential toxic effects to the thyroid glands and kidney. A newer drug called Depakote has now been found to help patients suffering from either mania or bipolar disorder. It is unknown how it works. Other antipsychotic medications have been used for bipolar disorder, including Risperdal, Goodin, Seroquel, and a combination of Zyprexa with Prozac called Symbiox, but should not be administered to elderly patients with dementia. Abilify has also been effective in treating bipolar disorder. Autism is a complex developmental disability that typically appears during the first 3 years of life and impairs the social connectedness that a person shares with others. Behavioral problems may include aggressiveness, severe temper tantrums, and self-injury. Risperdal has been used to treat autism, as has Abilify. Temple Grandin is perhaps the most famous autistic person and has recently been featured in a Hollywood film. Off-label usage is the use of psychotropic medications for purposes other than those specified by the FDA and is somewhat common. For instance, some antidepressants may be used or useful in the treatment of anxiety, and some anti-anxiety medications may be used in the treatment of depression. This is called crossover pharmacotherapy and has led to new advances and discoveries. Prior to the 1960s, the dominant approach to treating severely impaired psychiatric patients was institutionalization in large, state-supported mental hospitals, where psychiatrists and hospital staff treated patients. In the 1960s, a U.S. Supreme Court decision led to the idea of the least restrictive alternative and established that involuntary admission to psychiatric hospitals was permitted only if there were no other feasible means of treatment that would allow patients greater freedom. While this sounds good in theory, please note that many who suffer from mental health disorders are not able to take care of themselves or to make rational decisions about their own treatment. For instance, it takes a court order to make a schizophrenic person take the medicine that will give them a stable lifestyle. They fear this medicine because of their intense paranoia. Responsibility for patients shifted from centralized institutions to decentralized community mental health clinics with supposedly more humane settings. The process of deinstitutionalization was greatly accelerated by the expansion of federal Medicaid and Medicare programs, enabling thousands of patients to supposedly sustain themselves financially in the community. This rarely happened. Community mental health centers failed to live up to their promise to provide comprehensive mental health care, particularly with patients with substance abuse problems. The plan was half-baked, and there are a large number of homeless young adults displaying obvious signs of disorientation and distress. Many patients drift in and out of mental health facilities as they can only be kept for a certain amount of time unless they are a significant danger to society. One-third to one-half of all homeless adults have been diagnosed with a severe mental disorder. 250,000 patients with severe mental illnesses are in jails or prisons for psychiatric treatment that is often unavailable there. There are increasing rates of substance abuse problems in prisons. 400,000 elderly individuals in nursing homes suffer from some form of severe mental illness, and these facilities have often poor or non-existent mental health treatment. The quote in the book that it is unlikely that anyone will be advocating a return to the era of massive institutionalized care is false. The current system is not working, and mental health is seen as the least important health issue by governing bodies. I will see you in Chapter 16.